Welcome back. We keep on with this conversation. Patrick Kahonge and Stanley Wambui, thank you so much for staying with us. This is Good Morning Kenya. I'm Jain Wambui, and we are having our health conversation today, and we are just looking at how we can manage diabetes. But before we get to managing, what are we doing to prevent? But let's get to understand what causes it, to how to prevent, and if prevention will not work, how we manage that. Okay, this is Class 101. Hashtag Good Morning Kenya on Twitter, at KBC Channel 1, and at Jain Wambui is how you can reach me this morning. In studio once again, we have with us Dr. Nicola Oketch, who is an endocrinologist working with M. Fisher Hospital. Thank you so much for still being with us this morning. So now we want to continue just trying to look at some of those factors that expose us, or rather predispose us to diabetes. And we've talked about age being something that we actually do have a role to play. This is very individual. So age shouldn't be something that you use as a defense. Now, age and lifestyle all go hand in hand. Let's talk about weight issues. It is one of the biggest reasons that I have seen that brings about diabetes. But from a medical standing, what role does weight have to play in line with predisposing one to diabetes?
Of course, the more weight you have, the more resistance to insulin you have, and therefore the higher likely chance that you are to develop diabetes, more likely type 2 diabetes. Yeah.
How does that work? How is it that you're not able to, is it produce insulin?
No, it's sensing insulin.
Sensing insulin.
Yeah.
What is the barrier that comes into play, scientifically speaking, to just understand how that plays out?
Well, insulin usually has to send various signals to your body so that you can be able to handle the sugar. And if you have a lot of fat, that prevents the insulin from being sensed by the body, and therefore sending the signals for your body to absorb the glucose.
All right. And do you have to be extremely overweight or just over your regular or recommended BMI?
Over your BMI. But we also find people with diabetes who are within the BMI. Yeah, so it doesn't necessarily mean that if you're lean, you will not get diabetes.
Okay.
Yeah.
This goes back to also the genetic predisposition that could be there.
True.
All right. Now, another issue that you had mentioned earlier on is in regards to hormonal imbalances, and it all originating under the endocrine larger group. What role does hormonal imbalance have to play in line with predisposing you to diabetes?
In what sense? Sorry?
I find so many women, or rather from what I was reading online, you find women with hormonal imbalances tend to be exposed to diabetes or have diabetes, and I struggle to understand where the relationship comes in. What is the relationship therein?
Well, most endocrine conditions, hormonal problems, tend to be related, and I think what you're referring to is what we call PCOS, polycystic ovarian syndrome.
Yeah.
So that one, of course, one of the things that it's associated with is insulin resistance.
Okay.
And of course, if you have resistance to insulin, you're more likely to present with diabetes. Okay. And then, of course, there are other hormonal issues or endocrine disorders that put you at a higher likely chance of getting diabetes. One of them is what we call Cushing's disease, where you have very high levels of cortisol, and in that sense you're also unable to control the amount of glucose that is within your body. So most of the endocrine conditions tend to be very related. So if you find one, you'll always tend to look for another, and most of the time we tend to look for diabetes.
That could be underlying.
Yes.
Now, so that brings in the whole aspect of gender. Does gender have any effect or role to play when it comes to exposure to diabetes? Looking at ladies and gents on the other side of the divide, is there one gender that is, from what you have seen, a medical standing, has a greater chance of exposure?
Not really. The risk is equal, 1 to 1.
1 to 1.
Yeah, it's equal.
1 to 1. All right. Race. According to research, there's this general voice that those of African descent or native descent are at a higher risk of exposure than of Caucasian descent. Is that true?
It's
from
true.
medical standing.
It's true. Blacks tend to have a higher chance of getting diabetes, but unfortunately for us, we also don't know the specific statistics, especially in our African setting, because we don't do a lot of studies. You know, like in our setting, 1 in every 2 people with diabetes does not know that they have diabetes. So people are walking around with high sugars and they don't know. Most of the time we get patients who come to us already with complications, and even in evaluating that is when you find that the patient actually has diabetes.
Wow.
Yeah.
Again, it being a silent pandemic that we are seeing. Wow. Now, let's go to the symptoms that, you know, people come with, but they don't really know until things are becoming things, and it's too late. So let's talk a bit about some of those symptoms that could clearly be pointing out that there could be a problem, and more specifically diabetes, but we're not paying attention to. And I'd like for you to explain to us, looking at the differences between type 1 and type 2. Go for it.
Okay. So diabetes symptoms are very non-specific, and there's no one particular symptom that will tell you have diabetes. It's usually a combination of symptoms.
Okay.
In medicine, we refer to the symptoms as osmotic symptoms, meaning that they lead to a lot of loss of water. So one of the symptoms that we describe is you feel thirsty all the time, taking in a lot of water, you're always thirsty, drinking a lot. Then, of course, as you drink more water, you urinate a lot.
Yeah.
So you tend to pass urine a lot, you'll wake up at night to go to the loo, which is may not be normal for you. And then, of course, increased appetite, because your body handles is interpreting that you're not getting enough calories because your glucose is not going into the cells. But in actual fact, you have a lot of glucose circulating in your system, but your body interprets it like you're starving. So you'll eat a lot. And then, of course, non-specific other symptoms, like you feel fatigued. Some people will lose a lot of weight because they are losing calories through the urine. So those are some of the symptoms that we look for. When a patient comes with a combination of this, then we'll start to suspect that the patient has diabetes. And then, of course, you'll also look for symptoms which are related to the complications. So issues with their eyes, is there visual blurring, is there numbness or tingling in the hands or the feet, or a burning sensation? So those are the things we ask about.
Are there those that gain weight as a result of the eating constantly because you feel hungry?
Yeah, there's the risk of that also, gaining weight, because if your appetite is increasing, definitely you're storing more calories. Yeah.
Now, there's also this, at least for those who have already gotten to a stage where it's fully fledged diabetes, it hinders the healing process of the body. How does that play out?
It's related mainly to the blood vessels, because high blood sugar interferes with the way the blood vessels function, and the blood vessels carry oxygen and nutrients to wounds. So if the blood vessel is destroyed, there'll obviously be impaired healing. Yeah, and that's what happens in diabetes, mainly because of the sugar interfering with the integrity of the vessels.
Wow, so it's just one problem leading to another one. It's a chain of very tiny problems that at the end of the day put together this bigger picture. Now, let's talk a bit about gestational diabetes and just understand the complications that may arise as a result. First of all, for our expectant women who are watching us this morning, at what stage of your pregnancy are you supposed to get screening, at least for gestational diabetes?
Okay, I think we'll just have to clarify, there are people who already have diabetes and then they get pregnant. We always advise the ladies who have diabetes, if at all they anticipate or want to get pregnant, they have to make sure that their blood sugar is well controlled. But there's also this category of women who develop diabetes during their pregnancy. They have not known that they have diabetes, and
then not have had,
and they could not have
that.
Yes,
but
they could not have had. But it exclusively occurs during the pregnancy. Fortunately for us, in our antenatal clinics and in our antenatal programs in the country, at between 24 and 28 weeks of gestation, every pregnant mother or every expectant mother is supposed to undergo screening for abnormalities in their blood sugar. So they all of them have to undergo that. And if the gynecologist, or obstetrician detects an abnormality in their result, then they usually send them over to the endocrinologist.
Now, how is it managed during pregnancy? At least for someone who's watching us this morning and they have been getting a certain type of management, just to feel reassured that they are getting the proper management of their diabetes during the pregnancy. What are some of those things that need to be, or are standard for management during pregnancy?
As always, lifestyle. So of course what you're consuming, what you're eating, and then of course your physical activity. Just because you're pregnant does not preclude you from doing some exercise.
Yeah.
Then of course there's the medication. Pregnancy itself, not all drugs used to treat diabetes are safe in pregnancy or even in breastfeeding. We have a very narrow range of medications we can use. So if a patient has previously been diabetic and they have been taking tablets, there are some tablets we can continue to use. Not all of them, some. But if a patient develops the diabetes during pregnancy, we prefer to go straight to insulin injection because we know that will optimize, because what we're trying to prevent is a poor outcome for the mother and for the baby. Yes.
And what are the consequences of this gestational diabetes if left unmanaged and unchecked?
Abnormalities in the baby's development. Okay, so they'll probably be born with malformations. Okay, problems with the spinal cord, with the brain, with the heart. Okay, and then of course there's the risk of loss of the pregnancy. Okay, so early loss of pregnancy is also a risk, and then if the pregnancy progresses till time of delivery, there's also the chance that you can deliver a very delivering a very big baby. There's the risk of injuries to the child during delivery, injuries to the mother during delivery, even as far as death for both mother and child. Yes.
Just from something that can be managed. And can gestational diabetes continue to exist post the pregnancy, or in most cases, once the pregnancy is done, your body is able to control the sugar levels after the pregnancy?
Usually we'll find that the glucose levels tend to improve once delivery has happened. Some people will go back to being normal. They can handle their sugars normally, but we know that this particular person who has had gestational diabetes is at risk of developing diabetes as compared to someone who has not had. Okay, and then there are also this category of people who will continue to have abnormal sugars even after delivery.
As a result of the gestational.
So monitoring is very important after delivery. I know some people get lost to follow up, but even for the gynecologist obstetrician, they need to advise their patients that once you deliver, if you have been diagnosed with gestational diabetes, you need to follow up with that. Regular sugar checks. If you need treatment, then you can be referred to the appropriate specialist.
I know. So mothers, we need to... Clinics post-pregnancy are not just for the baby. Yours are also important in as much as so many people after pregnancy, clinics are focused on the child. The mother is left to just, take the child, go back home, care for the child. Help yourself. Get checkups. If you don't have a personal doctor, I believe services are made available in most public hospitals to just see how you are doing post-pregnancy. Now let's go to the management bit of it all, and I'd like to start off with the gestational diabetes, or even just before we even get to managing gestational diabetes, when it comes to testing for diabetes, how does that happen?
Just a random blood sugar check. That's usually a screening measure. However, we cannot use the random sugar. When I say random, I mean you just walk into the clinic, they check your sugar. You don't necessarily have to have fasted. But that particular sugar, what you call the random sugar, if it is abnormal, we cannot use it to diagnose diabetes. You actually have to recheck it again, or you now inquire from the patient, do they have the symptoms that are typical of diabetes? Okay. The most specific measure would be to probably do what we call a fasting blood sugar, which is the blood sugar test that you do. We tell our patients to come in the morning before breakfast, because they should have had an overnight fast of between 6 to 8 hours. Okay, so after supper, nothing in between that time and the test.
Even water?
Well, water is okay. But yeah, we tell them, I mean, you're not going to wake up to drink water at night, and I mean, unless okay, that's it. Okay. Yeah, so fasting sugar. But there's a specific test that we call the OGTT, which is the oral glucose tolerance test that we tell our patients to go and do. And then that one gives us an indication of, do you lie within the normal range, do you lie within the pre-diabetic, or do you lie at the diabetes range? Okay. Because it's always good to identify those people with pre-diabetes, because those are the ones you can target to also prevent them from going to diabetes.
All right. Yeah. How often should you have a check done to just check your blood sugars, how often would you recommend one has it done?
If you have a family history of diabetes, it would be advisable to do it in your annual medical checks, okay? But if you've had like gestational diabetes, especially after delivery, you would do it more frequently. Within the 6 weeks, we usually target the mothers at that 6 weeks when they bring their babies to get their vaccinations. So we check them then, and then of course, if there's nothing, then we follow them up maybe after 3 months, 6 months, and then yearly after that. But especially for people who are getting older in age, after 40 years, you tell them to do your annual medical checkups and check for your blood sugar.
Check on the blood sugar.
Exactly.
And even for those young folk and they don't have the family history, how often would you recommend, also not looking at gestational diabetes being a problem, just a regular young person minding their business, how often would you recommend they have a sugar test done?
Well, if they're lean, they're not obese, okay, maybe once every 3 years, that would be acceptable.
All right, just get it done. It won't hurt to just know. Most of these things we come to find out when they are blown. Now, the management bit of it. Let's start with diet. This is something that so many people struggle with, and especially looking at weight. We want to eat the sweet things, we want to eat the processed things. Junk food are always ready, available for everyone. How can we have a diet that is good for us and it's also delicious to eat? Because again, junk is always good, ni tamu, but the consequences are harsh. How can we have a diet that is healthy and delicious and also just safe in terms of sugars?
Well, the diet is always available. It's about the intention to choose what is right for you.
Yes.
So we always give our patients or people who are looking to adopt a healthy lifestyle the plate model. So when you look at your plate, provided it's a normal size plate, not something
it is normal, the side plate, not the dinner plate.
well, a reasonably sized round plate. So half of it should be vegetables, okay? And then a quarter should be your starch and a quarter should be your protein. If you really want to estimate, you can say this, the size of your fist is the size of a quarter, so the size of your protein, size of your starch. Then both of your palms together should be the size of the vegetable serving that you give yourself.
Okay.
Yeah.
And looking at starches especially, are there those that you discourage? Let me use myself as an example. Mi napenda waru. All forms of potatoes in the different shapes and the variants it comes in. So you find somebody might overeat on one kind of a starch and use it as, you know what, I'm eating starches as has been recommended. Also balancing the portions and frequency. Does that have a role to play in all this?
Definitely. And also when you're advising our patients, we tell them go for less refined starches. Avoid the white starches, but we know of course those are the ones which we find more available.
My heart.
Your white ugali or chapati, you know. So watch your portions. Watch your portions. I think that should be the take-home message. Watch your portions.
All right. Exercise. One might argue, okay, I'm not big, I'm lean, so exercise is not really for me. I'll just mind my diet. Adopting exercise as part of your routine to help with the management and prevention of diabetes. What would be your advice to this end?
We say 3 to 4 times a week, exercise between 30 to 40 minutes during each session. And then you have to combine both anaerobic and aerobic exercises. By aerobic, I mean something that will get your heart pumping, so like jogging, running, a brisk walk, swimming, okay? And then anaerobic are the lifting weights, basically to stretch your muscles, because you have to do, other than your skeletal muscles, you also have to exercise your heart, which is a muscle. So that's why the aerobic and anaerobic combination comes in.
All right. Now, I came across hydration as part of the management bit of it. Help us understand how staying hydrated is in line with self-management towards the prevention of diabetes, if it is to start with.
Well, I wouldn't really call it, well, if you mean hydration with water, then that's acceptable.
Staying hydrated throughout.
Well, I would say from the way I think about it is that the more water you consume, the less hungry you are and the less calories you will consume. So in that way, it curtails the amount of calories you're taking in. Yeah.
Okay. Now, self-management education, and this brings in the aspect of insulin, at least for those who have to take them on a daily, and the education bit of it all for those who actually have diabetes, and why it is important to know how to self-manage and self-administer insulin. Importance of that.
Self-management is very important because at the end of the day, you're not going home with your doctor, you're not going home with your nurse. So you also have to understand how to manage your own blood sugars. Ideally, when we have a session with our patients, we always tell them the targets of blood sugar that you're aiming for. And targets are individualized. I wouldn't give you the same target that I would give an 80-year-old person with diabetes.
Yes.
So they are always individualized. So it's always important for you to consult with your doctor, and there is always a diabetes nurse educator. We have them in MPSHA, and a nutritionist. So that encompasses the whole aspect of self-management of diabetes.
Yes, you need to know how to manage yourself in the event of anything. You don't suffer harsher consequences. All right. Prime Movers is asking, could Dr. Nicola elaborate on endometriosis?
Endometriosis is a gynecological.
In line with diabetes, if there's any relationship.
No, there is no relation between endometriosis and diabetes.
Okay.
Endometriosis is actually a gynecological problem where there, I mean, I'm not a gynecologist, but at least I know
the basics.
There's abnormal uterine tissue in other parts of the body outside the uterus.
Okay.
Yes.
All right. Lil Baby asking, what is the relationship between diabetes and sight loss?
It's a complication of diabetes. What usually happens, because there's an abnormally high blood sugar level all over the body, it includes also the eye. So when there's high glucose, it draws water. Glucose draws water wherever it goes, okay? And the accumulation of glucose in the lens of the eye draws water and makes your sight hazy. Yeah, so that's what happens. That's why you get abnormalities in the vision. And in addition to that, as I mentioned before, it interferes with the blood vessels. So as it interferes with the blood vessels, particularly the small ones, which are also found in the eye, in the kidney, and along your nerves, it will also compromise your vision.
Is it reversible, and especially for the eyesight? Can it be corrected?
Okay, it depends on how severe it is. In the early stages, definitely, but later on, sometimes it might need to sight loss.
All right. Now, as we draw this conversation to a close, maybe you could just take a minute or so to just talk to our viewers when it comes to the importance of being very careful with what we take, because at the end of the day, what we eat is what will determine our exposure to diabetes, and consequently what we can do to prevent it as a whole. Just general message to our viewers this morning.
Yeah, so being conscious of what you're taking in, as you mentioned, try and make it intentional that you pick the right foods. And sometimes it's kind of difficult. I find most of my patients come to me and tell me, oh, you know, Daktari, I went for a conference and, you know, I can't control my diet when I go to a conference. But there's that buffet there, and there's this serving of vegetables and there's this serving of chapatis. You've chosen to take 10 chapatis and leave out the vegetables. So it's about an intentional effort to pick what is right for you. And then, of course, exercise. Everyone should be incorporating some form of exercise according to your ability, so that you keep your body moving.
All right.
Yes.
J. Kim is asking, just before we close, can a vegan person be exposed to diabetes?
Yes. We have quite a number. We have quite a number of patients who are vegans or vegetarians, and they do have diabetes. So as I mentioned, genetics also plays a role in that. And the older you get, of course, your genetics comes in more.
All right. Thank you so much, Dr. We have been speaking with Dr. Nicola Oketch. She is an endocrinologist working with MPSHA Hospital. This morning, you're helping us to understand what we need to do to manage ourselves. Be your first micromanager. Look at what you are eating, what you are putting into your body, and how it is helping you. Is it good? Is it bad? Or it's ish-ish? If so, decide, because I mean, at the end of the day, diabetes is a lifestyle disease if you do not have any genetic predisposition. So be your first line of defense. Thank you so much for being with us this morning.
Thank you.
We appreciate you for making time.
Asante sana.